We wanted Dr. Paulina Salimeni to stay in the room.
Do you understand Italian? What's the difference between these two, Indrietto and Inviodati?
I'm not sure. Sometimes look similar to French, but sometimes and you're trying to.
So this is going to be fun because
Try the
it's Friday. We're close to the last sessions of the day. So speakers, I will encourage you to present to the other speakers very closely and careful. Thank you for everybody that is attending the meeting. So what we're going to try to do is just have some of the leadership of the North America chapter talking to us about up-to-date issues. And at the end, we're going to have an exciting debate. So Teresa Lamasters is going to start with combination use of obesity medication with bariatric surgery to enhance outcomes. Teresa is the immediate past president of the ASMBS. Teresa.
Do you have the clicker, Jaime? Jaime, you have the...
looks like we're talking about ourselves here.
Yeah, exactly.
Oh, no, here
Just
it
the
is. Okay.
speakers.
All right. Oh, let's go back. Okay. Well, thank you for coming out on a Friday. I will tell you that I have more information here than we probably have time for, so I'm going to go fast through some of it. Some of you guys, of course, are my dear friends, and I want to thank, again, Jaime and the organizers for inviting me. But we're going to talk about a topic I'm actually very passionate about, is combining medications with surgery. So these are my disclosures. They're not going to impact my talk today, even though I do talk about medications. This is my career case mix disclosure. Still definitely heavier sleeve, but a combination of procedures over my career. So first I'm going to introduce the topic about bariatric surgery working through gut-brain neurohormonal pathways and talk about the variation in response we see with surgery and then how we can use medications to enhance that response. So first of all, I think we need to start with the statement that what we do works really well. Bariatric surgery is very effective, but not everybody responds the same to this fantastic treatment that we have. And understanding that variation is something that we're just early in our ability to understand. So there's a limit in what we can do with surgery. With surgery, we can do something very unique. We're essentially able to reset the set point lower, so the body's idea of normal, lower with surgery. We can't do that with any other method. But the question is, can we push it even further? So again, we talk about there is a variation in response to our procedures. So we think about the mean and 1 and 2 standard deviations off of the mean. This is one of my favorite papers because essentially they created a growth curve or weight loss curve for bariatric surgery for bypass and sleeve. But what was very helpful to understand is that 16% of bypass patients would have been considered a poor responder from their initial surgery. But all patients have some weight change over their nadir. That is actually not unexpected. That is expected, but we need to define when that's pathologic. So we also need to talk about what are realistic outcomes with bariatric surgery. We know that 3/4 of all bypass patients are never going to reach a BMI less than 25, and 1/4 will never reach a BMI less than 30. So we need to talk about that with patients, about what's realistic. To understand our discussion today, we need to start with obesity as a chronic disease. It's a disease of the brain. Now, what do I mean by that? It's not that our patients are crazy, it's that our brain controls hunger, satiety, and how our metabolism works. And this is through a complex connections through the gut and the brain. And this is just a simplified cartoon to demonstrate how these mechanisms work to control appetite and energy expenditure. But I will tell you that our surgery is not about forcing people to eat less or about not letting them absorb their calories. It's about changing biochemistry, and that's really important to understand. Also, that different procedures have different mechanisms of action. This was a great paper talking about the mechanism of action of a sleeve. It's not a restrictive procedure. It is a metabolic hormonal procedure, and in fact, it's more similar than different to the Roux-en-Y gastric bypass. It works through the same gut hormone neuropathways as the bypass. So one of the big hormones that we're talking about a lot, because a lot of medications are coming out in this range, is the GLP-1 agonist. So what's a GLP-1 hormone do? Well, it is key to improving blood sugar control, suppressing glucagon. It does delay gastric emptying, but it has direct neuro signaling pathways direct to the brain. So when we look at the sleeve and the bypass, we can understand in a lot of ways they're actually very similar, but they do have some differences. One of the big things is when we remove that section of stomach, we're actually removing a lot of the cells that create a hunger hormone called ghrelin. So the sleeve is fantastic at dropping ghrelin levels and decreasing hunger. It's good at improving GLP-1. Now the bypass is actually not great at ghrelin. In fact, 3 years after, a lot of patients have increased ghrelin after a bypass, but it's really very good at GLP-1 increase, which is a satiety hormone. This is why it's more powerful for type 2 diabetes, is because of that increased GLP-1 effect. But really, again, they're more similar than they are different. So understanding the variation in response to procedures. So this was a great study looking at patients who had weight gain after gastric bypass and identifying that many of those patients actually had less of a GLP-1 response, and that may have played a role in their weight regain. So I always ask this question. So, okay, once we understand there's variable response to our procedures, can we alter the patient's response to surgery? And I would suggest to you that yes, we can. And how do we do that? Especially with medications is one of our options. So I will tell you that physiology drives behavior. We like to blame behavior, especially when patients aren't doing well with surgery, that they're just not doing the right things. But if we can control abnormal physiology, we can control behavior. This is a demonstration of how the body adapts to weight loss. Now, this is actually a medical weight loss curve, but we do see a similar weight loss curve. It's just flatter with surgery in the sense that once we get through a weight loss phase, the body can upregulate hormones that can increase hunger, decrease satiety. Well, with surgery, we can definitely flatten that curve, but I just explain it to patients as we're impacting about 2/3 of the known connections between the gut and the brain. That means 1/3 are still not normal. And this is a disease we're going to treat for the rest of your life. So we can use weight loss medications to augment the effects of surgery. They work through the similar pathways that we do with surgery, and we can use them prior to surgery, after surgery for those with inadequate weight loss, or those we just have more severe disease who need additional therapy. This diagram is just to give you an idea of how these weight loss anti-obesity medications work. They work through these same brain pathways that we are working on through surgery, but they are highly selective. They get to work on one pathway, maybe two. The newest one's going to work on 3. But we're working on about 20 known gut hormone pathways. Much more powerful, but we are using the similar pathways as medications. This was one of the earlier studies on use of medications after bariatric surgery for weight regain, and this was in patients with Roux-en-Y gastric bypass who'd had some weight regain. And they started with the medication topiramate and then added on a layered therapy of phentermine. And what they were able to demonstrate is that they could reach a lower nadir by adding the medications on top of surgery than they even could with surgery alone. And that they found that the additional weight loss averaged 20 pounds per patient, which is really very significant, especially when we think about how much weight loss we can get with revisions for patients comparing to medications. So this is another pivotal study that looked at using medications essentially to downstage disease pre-surgery, because there was a lot of discussion that we shouldn't do sleeves for high BMI patients because it's just not powerful enough. We need a more powerful tool. Well, this demonstrated starting medications pre-surgery and then continuing them for 2 years after. And this was a phentermine topiramate combination, started pre-surgery. All these patients had a BMI higher than 60 and had sleeve gastrectomy. So the group that had medications plus surgery, about 2/3 were able to reach that BMI less than 40. And this is starting with a BMI greater than 60. Without the medications, less than half were able to reach the BMI less than 40. That was an odds ratio of 4.1 for the medication plus surgery group. This is a more recent study that was just in Sorrento in 2023 this year. Again, high BMI patients greater than 60. These were both sleeve and bypass patients, but heavily sleeve patients. And they found that the group that started medications pre-surgery and continued them in combination with surgery had a total body weight loss of 31%. If they started the medications a little later after they identified them as having suboptimal or inadequate response, their total body weight loss was 25%. If they did no medications, surgery alone, so no combination therapy, only 20.8% in this high, essentially severe disease group. So I use a lot of medications in combination with surgery in my practice, both pre-surgery, post-surgery. There are lots of things I think about when starting these medications, about the individual patient, what is the procedure they had, what comorbidities do they have, and many of us who use these therapies use layering therapies. We can use this to fine-tune our treatment response. Many of these medications have side effects that are dose-dependent. So you don't have to go to the highest dose. You can back off on the dose if they're having side effects and still be very effective. What I tell people is, especially if you're using a GLP-1, think about it this way. A lower dose of the GLP-1 can be very effective after surgery because we're already stepping on that gas pedal. So a little bit can go a long way. So you don't have to use the full dose of medication. I will tell you that data in this area is emerging. This is a lot of art right now because many of us who do this routinely, it's very hard to study it. The databases are not comprehensive, and most of it's going to be retrospective data. So when people ask me for my algorithm, I tell them I would love to give it to you, but it starts with number one, what can I get my hands on for this patient, which often comes down to cost or insurance coverage, rather than what would I actually like to give this patient. So I have a few examples. This is a pre-optimization patient, so think of this more as like neoadjuvant therapy. So this was a 42-year-old female with a BMI of 51. She had multiple comorbidities, kind of the standard ones we see. She also had reflux, but she was on a lot of mental health, mood-stabilizing medication, and she'd had a significant number of kidney stones as well. She was started on metformin and lifestyle management and was optimized and lost 22 pounds over 6 months, so about 6% of her total body weight. So when she came to see me for surgery, her BMI was 48.5. She was already actually fairly optimized, and she wanted a sleeve gastrectomy, which I felt was very appropriate for her, and we could talk about that at length later. But she said, you know what? I talked to her about her realistic outcomes, and she said, well, I want to do better. I want to get down to 190 pounds, which would have been about a BMI of 28 or 75% of excess body weight loss. So what we did is we added semaglutide and tapered up the dose, and she was able to lose an additional 27 pounds, or another 8% of total body weight. So we lost 14% of total body weight using 2 layered therapies prior to surgery. She had side effects, so we backed off the dose, still were able to be effective. So I'm gonna skip kind of fast through here, but she had a sleeve with a hiatal hernia repair. 7 weeks post-op, had lost 45 pounds since surgery and 94 pounds since starting this process. So she was already at 27% of total body weight by 7 weeks post-op. We restarted her semaglutide at 7 weeks and gradually started to increase the dose. The patient had some side effects. We decreased the dose. The long story short is 6 months post-surgery, she was down 106 pounds since surgery, and she had lost a total of 45.5% of total body weight loss. So this is an example of combination therapy, but starting pre-surgery for optimization and continuing post-surgery. And this is what that looks like as a graph. So much better result than you would think with surgery alone. This is combination therapy. So this is somebody who had initial expected weight loss, but then had weight regain with post-op rescue. And so this was a 41-year-old female with a BMI of 40, so not super high BMI. Her lowest weight was 185 pounds, so she had lost 28.9% of total body weight, which was a pretty good response for a sleeve. So 3 years later, she started to have some weight gain. And so she has still maintained some weight loss, but only 39 pounds, 34% excess body weight loss, but 15% of total body weight loss. So first we started with metformin. It's cheap, it's easy to get. Then we added on phentermine, again, cheap, easy to get. Then we added on topiramate. So now she's 5 years out. Her weight's back down to 175 pounds with a BMI of 27. Lost 75% now of excess body weight, 32.7% total body weight. So this is an example of rescue after initial expected response, subsequent weight regain, and this was a phentermine topiramate essentially combo. And this is what that looked like. So she was able to get lower than her original nadir by adding medications, even after she had had weight gain. So here's an example of late regain. She'd had an initial good weight loss with the sleeve. She was an older patient, 63 years old. Her lowest weight post-surgery was 76 pounds of weight loss with a BMI of 24. She'd had 33% of total body weight loss. Very good response with the sleeve, very expected. She got lost to follow-up, came back 9 years later. Actually, almost by the time we intervened, it was more than 10 years later. And she'd gained a significant amount of weight. And we've all seen this in our practice, right? So she was down to a 19% total body weight loss. Still good, but not where she wanted to be. So she had type 2 diabetes, which today would give us more options for treatment as well as some other health issues. So she got to start on semaglutide, which we don't get for everybody, improved her blood sugars, but also had some weight loss. So essentially we adjusted her dosing, we added phentermine, which helped with some fatigue. And this is, again, the art of layering these therapies. So we got her weight down to 149 pounds with a BMI of 24. After medication intervention, she'd lost an additional 33 pounds. So, stuck. Can you go forward one? Okay. This is what that looks like on a graph. Again, we were able, even though this was late weight gain, able to get her below her initial nadir. So we're going to skip over to just the graph on this. But this was a bypass patient. Just so you understand, this is not just sleeve patients. This is a bypass patient who had had 9 years post-bypass, regained weight. We started phentermine topiramate, and then we added liraglutide because this is a patient we could not get semaglutide for. Excellent response, lost 27 pounds additional, 27% of total body weight loss. This is usually what I hear. Oh my gosh, that's overwhelming. Can I do this? And the answer is yes, you can, but you can get help. And this is really the future of where we're going. Understanding that we can downstage disease for severe patients, we can have surgical management, and then we can have adjuvant therapy. We can use combined therapy for our patients to get better outcomes, especially in patients with severe disease. So what this means is I do a lot less revisions for weight regain. I do them for complications, but way less for weight regain. I start with medications first. So helping to understand that we are actually changing physiology and biochemistry, and these medications can help us, is really the path to the future. So hopefully we can have some good discussion on this. And thank you for your time and attention.
Marina, are you in a hurry to leave or not? Are you in a hurry to leave? So, like, we can skip you because Omar has a flight to take. So I was gonna let him go first and then move on. So we're gonna make a little change on the agenda just because the next Omar Ghanem is gonna have to leave to the airport sooner. So my idea was before the debate that we can set the stage in between OAGB and SADI, but you're gonna present us. You set the stage. You're gonna present us the data, especially the MBSA QIP data. There's a good paper that you review on those two one anastomosis procedures, and then you can leave after that.
Thank you, Marina and Pierre, for the adjustment. And thank you, Jaime, for the invite. It's an honor to be here. This is a presentation today on the MBS QIP data on OAGB and SADI. And later, Dr. Lutfi and Dr. Billy will be debating on the topic and which surgery is better and which surgery is worse. I have no disclosures, and my case mix is mainly about 40 to 50% revisions, and the other is divided between all procedures. I do not do OAGB. So why did we publish on this? My good friend and partner in crime, Ben Clapp and I tried to benefit from MBS-equipped database and what it provides from the large numbers to provide data on some of the procedures that might be performed in the US with lower numbers in single centers. And the idea came from why these surgeries have to be compared. One is because of both recent endorsement and adoption in the United States. So ASMBS and has recently, I believe 2021 and 2022, have endorsed SADI and OAGB respectively. They both have a loop configuration. If you look at this, really, the main difference is the pylorus. At the first glance, that's the main difference. But then if you go into the detail, you notice that these surgeries are different more also on the common channel length, and one is the ileal bypass, the other one is a jejunal bypass. And these are different physiologically. The third reason for comparison is that both are hypoabsorptive procedures. So those procedures, again, hypoabsorptive. They are not restrictive mainly, and they work with hypoabsorption, especially the long term. And the last reason for the comparison is the scarce comparative data in between these two procedures. Although they are being performed in Europe and in the Middle East and the MENA region and India, South America, and recently in the US, we have very limited studies to compare these two procedures. Both surgeries are being advertised to be ideal operations. When we talk about ideal operations, we talk about acceptance, efficacy, reproducibility, and safety. When it comes to acceptance, now both are accepted in the United States as procedures. Now, of course, insurance approval is lagging, but you are not faulted as a surgeon if you are performing a SADI and OAGB, since there is an ASMBS endorsement for both procedures. When it comes to reproducibility, one is surely reproducible, the SADI, and the OAGB, there is multiple versions for it, so I don't know which one is reproducible, but at least we see, or there is a claim that it is a very normalized or standardized operation, except for the BP length that can range between 150 and 200. When it comes to efficacy, there are comparative studies that are limited to about 50 patients in each arm, and 2 studies, in fact, and both are revisions after sleeve with comparative data. So same efficacy. The only thing that we don't know anything about is safety. And really, it comes, before I jump into the MBS-equipped data, I'm just giving the introduction. It all comes back again to the pylorus. I'll let Rami and Helmuth fight when it comes to bile reflux and the incidence in OAGB versus SADI. I'll let also Dr. Lutfi and Dr. Billy fight when it comes to dumping syndrome and ulcers and the difference between OAGB and SADI. All what I can say is that this was accepted yesterday, that after 20 years of us performing SADI and DS, this is the first study that truly evaluates ulcers and dumping syndrome in a surgery that was designed to avoid ulcers and dumping syndrome. That's the duodenal switch part, and we are at less than 1%. But again, these are all on the long term. What is lacking is the comparative early safety data. This study was published in Obesity Surgery in 2023. Dr. Pons, Dr. Moore, Dr. Billy were parts of the study as well. And again, me and my partner and my good friend, Dr. Clapp, were leading the study. So we checked the MBS-equipped POF data for years 2020 and 2021. And for those who don't know the details about the MBS-equipped, before you could not really evaluate the procedures other than sleeve, bypass, and sometimes DS. But the 2020 and 2021 allows us to know the details about these procedures. So we checked the CPT codes, and we excluded all procedures, combined procedures, except for EGD, hiatal hernia, and that's it. So all combo procedures were excluded. If we look at the baseline characteristics, we see that the body mass index, so the age and the sex are similar, but maybe also the age is a bit higher in the OAGB. But when it comes to BMI, the SADI is being offered in the United States for patients with higher BMI. And that might be the reason, because people think that the mini bypass is a mini, or the one anastomosis gastric bypass is a mini procedure. It's not. It's a hypoabsorptive procedure. When we look at ASA, we notice that a lot of the patients in the SADI group are ASA4, and that is because, and we'll see later if you go down, a lot of these patients are on immunosuppressive therapy, and this is, again, p-value is less than 0.05. So reasonably, and that is correct, for the right reasons, SADI is being offered for patients who are on immunosuppressive therapy, because, again, the chance of ulcers are pretty low in the duodenum rather than in the gastrojejunostomy, rather than the duodenal ileostomy. When we looked at the outcomes, we noticed that the SADI had more complications. Grade 4B complications, these are serious complications. We're not talking about a mild UTI like in grade 2 up there, but these are serious complications. Had more serious complications than OAGB. Not leak. Leak rate was similar. This debunks the fact that the duodenal ileostomy is a more risky procedure. It was mainly pneumonia, and it might be related to the higher percentage of patients who are ASA4 that are getting SADI and who are on immunosuppressive therapy. It wasn't leak. Leak was similar in between the two groups. When it comes to reoperation and reintervention, these were the same. The readmissions was higher in the SADI group, and again, it is related to the fact that they had more complications when it comes to serious complications. But again, for a good reason. For a good reason, because these are different populations that we're comparing. So, in summary, if you look at the study, you think that the SADI is a more risky procedure. That is not correct. It's just being offered to a higher risk population. That the duodenal ileostomy seems to be as safe as the gastrojejunostomy. So that is also against what we thought in the past. Although, again, these are both in the, I would say, in the learning curve process for both operations. There is higher readmissions for the SADI group, but this is again related to the serious complications in this group. I bet it's going to be a very interesting discussion between Dr. Lutfi and Dr. Billy. I personally think they are very similar operations, and you can tailor them both relative to what patient you have. But I'm sure Dr. Lutfi and Dr. Billy will bring more excitement to that. Thank you.
Actually, Omar did perfect, because I wanted to, as Teresa took a little bit of the extra time, so we can ask questions to both of them before Omar leaves. Summer, do you have a question, Pierre?
I did have a question for Dr. Lamasters. Thank you. That was a very good, comprehensive overview of how you're using medications in your practice. One issue that I have is, you know, in your patients, this was initiated after they came back, in some cases several years later, and was the trigger for treating them. But when I'm following them on a monthly, not a monthly, you know, at regular intervals, I'm not sure when to intervene and decide on whether to start treatment. You know, I sometimes say, okay, we'll see you next time and see how you're doing. When do you actually, in the patients who follow up with you regularly, what triggers you to initiate medication?
So this is a great question. My practice has evolved entirely. It used to be just for rescue therapy, and then it became much earlier, by 9 months, by 3 months, then pre-surgery optimization, and then continuing medication. So it really does depend on the patient. But I think by 3 months, you can tell if they're not on their expected weight loss curve. So what the data shows is it's much better to intervene earlier when they're at a plateau, so to speak, rather than after they've had weight regain. So some of these patients, yeah, they don't come back till later with significant weight regain. but you can recognize it, I think, as early as 3 months. And in patients who we consider severe disease who need combination therapy, we continue it in the early post-op period. But this is a great place for research because we don't know if I continue them on a GLP-1 agonist that they started pre-surgery, or I start it really early after surgery, like we're talking the first couple of weeks, do I suppress that natural GLP-1 surge that comes from surgery? Or do I just augment it? We don't know that. Right now, I can tell you that I usually continue the medication, but I decrease the dose because we're stepping on that gas pedal so hard with surgery. If you keep them on the same dose, they can have a lot of nausea, they can have hypoglycemia, they can have a lot of side effects. So a little bit goes a long way if you continue it, or stop it and restart it at 6 months, or 6 weeks, I mean. But by 3 months, I think you can have a good idea if the patient is on their expected
3
curve.
months. And just to follow up quickly, do you have an algorithm? I notice you start with the simpler medications or the more common ones, metformin, phentermine, so on, or do you go straight to GLP-1 agonists?
He stole my
So-
questions. Those are the exact ones.
Oh, good. Well, it's 2 in 1.
alike
So
then.
in a perfect world, I could choose what's right for the patient. And I would choose that based on their comorbidities, their level of metabolic disease, did they have diabetes before, which procedure did they have, things like that. In the real world, a lot of it has to do with what can I get my hands on. So a lot of them would benefit from the GLP-1s or like the GIP, if I could get my hands on it. And that's just not a realistic possibility for a lot of these patients. So even though they're not going to be as powerful, so my Medicaid patients are the best example. Like I can't get anything for them, right? So, but I can use phentermine and metformin as a combination. It's cheap, readily available, and I can still get some benefit. It's not going to be as powerful as if I could put them on a GLP-1, but they're going to still do better than if they didn't. So honestly, for most patients, if you can get a GLP-1, some of the versions of it, they're going to have the most power. However, some patients, especially bypass patients, if they already have a good GLP-1 response and you give them a GLP-1, it can cause hypoglycemia. I think some of those patients that we see hypoglycemia in after bypass, it's too much of a GLP-1 response. It's too strong. So phentermine topiramate can be a better combination for some, especially bypass patients.
Thank you. Dr. Clapp?
Well, that was kind of my.
Hold on a second. Let me make a comment here following this. So there's 2 concepts. One is weight recurrence, after bariatric surgery, and the other one is the suboptimal initial weight loss. And so I was very intrigued yesterday we were in another session. So this the only randomized clinical trial that has combination of bariatric surgery with medications is that very optimized. That what they did is at 1 year they used sleep patients and bypass patients that didn't lose more than 20% of the total body weight. At 1 year, they started with liraglutide at a maximum dose of 3 milligrams, and they had an 8% attribute. But how much of that could be associated to just lack of a little bit more time for the surgery to respond? But it seems like it was a significant difference. The placebo group lose nothing else, and so you would assume that those patients in general are not going to lose any more weight at 1 year. Do you think that's early enough to start medication?
I do. And you're right, there are 2 different groups. There's inadequate initial response and there's weight regain, and there are probably different physiology that's going on between those groups. But we don't have enough data to exactly understand those groups. But yes, I think definitely by 1 year you can tell where they're at and if they could benefit from combination therapy. So I definitely say start early.
I want to add one thing, and truly there is not much data, but 2 comments. One, there is a recent study about the real effect of those medications versus what we're seeing in the randomized control studies, and there are completely different responses. If we're talking about 22% versus probably 10 to 14% in real world, that's number one. The other comment I have is personally, I put patients on very low caloric diet pre-op, and I feel that the weight they lose pre-op deducts from the weight they're gonna lose post-op. So it's more of a combo weight loss. So patients at one point reach some plateau. It can be pre-op, it can be post-op, it can be both. But I feel once they reach that plateau, that's it. And maybe I'm wrong because I haven't studied that, but truly the patients who lose 30 pounds before the surgery don't lose more after the surgery.
So again, that's probably a variable response. We know that some actually do. If they lose surgery or lose weight pre-surgery, they have a better total weight loss than they would have. But you're right, for some people, it's like, well, that was just part of their reset of their set point. They can't go lower. But that's the big question is, can we drive that set point lower if we use the medications earlier? While they're still on that trajectory, essentially where their brain's resetting their set point, if we use the medications there, could that set point be lower? Because we all have those patients who you say, you're going to be 180 pounds, and they're like, well, I want to be 150 pounds. So if I just work harder, I can get to 150 pounds. And we say, no, you can't. Why? Because your body's idea of normal is here, and it's going to defend that just as vigorously as it did up here. So you can't just work harder and get it lower. But with medications, that 10%, that 15%, you get that on top of the surgery. It's bonus weight loss on top of the surgery. So wherever you started, you get that same response. Now, the thing is, not everybody responds to the medicines the same. It's the same bell-shaped curve, right? So they're preaching this little piece here, but you're right, not everybody. Some people have a 5% response. So if I put somebody on a GLP-1 and they don't respond well, and they had a sleeve, they may not respond well if I convert them to a bypass.
Thank you, Dr. Therese.
Okay, thank you.
I think Pierre had a question for Omar quickly, before you leave.
One quick question.
One quick question, one quick answer.
Yeah, just quick question, Omar. When you revise the MBS equipped data about the pre-op GERD symptom, have you found any information? Because some surgeons avoid to do OAGB if the patient complain of GERD symptom, even if it's well controlled with medication.
You want the truth?
Yeah.
The GERD data in MBS Equip sucks. That's the truth. You want a personal opinion? Both are reflexogenic procedures, and if a patient has reflux, I would advocate against both SADI and OAGB, and I'm probably one of the biggest fans after Torres himself for the SADI, but I wouldn't offer a SADI for a patient with severe reflux.
I agree.
Thank you.
I'm sorry, Omar, that you're not going to stay when Pierre presents his data on OAGB. Marina, our president of the SMBS, is actually going to talk to us about a little bit of issue that we have, you know, the esophageal function in bariatric surgery. Thank you, Marina.
Thank you for the invitation. I'm going to try and stick to time here. Okay, these are my honoraria. They actually have nothing to do with what I'm talking about today. Here's my case mix disclosure, my total case volume. Okay, so how do we measure esophageal function, normal esophageal function? This used to be like, ugh, did I just get a manometry report and I would only look at, it's like cheating and just reading the abstract, which I do, guys, which I do. So I would just look to see if they had effective swallows or not. But there's so much more that you can get from a manometry report, and also there's impedance manometry, so things that we need to know. So I'm going to go through that with you. This is a great article, details all the esophageal diagnostic procedures and what you can find out for them. And so the main things that we're looking for are integrated relaxation pressure, the DCI, and we look at the CFV and the distal latency. I'm not always looking at intrabolus pressure. And the IRP, excuse me, the IRS I have to deal with too, so that's different. Okay, the IRP represents swallow-related EGJ relaxation pressure. So if what it will tell you is if there's impaired EGJ relaxation. The new Chicago classification came out with new gastric outlet obstruction criteria, and so this is sort of, the IRP will help you there. The DCI is that me? Or is there a bird? Okay, the DCI measures magnitude of contractile vigor and what it can tell you about hyper or hypocontractility, but I also use that to sort of see how well is someone's esophagus squeezing. CFV, again, assesses peristaltic velocity, and the distal latency is the time from the onset of the swallow from the upper sphincter to when it reaches the distal esophagus, and it can tell you if there's spastic contraction. So normal DCI is like the TSH range, really broad, 450 to 8,000, but I kind of think that if it's under 500, it's not really great. And then again, the distal latency is just the start of the swallow to the inflection wavefront before the EGJ. And then peristaltic integrity, you're looking for gaps in the contraction, which will tell you if they have fragmented swallows. So most people consider dysmotility a DCI less than 450, failed or ineffective swallows, LES pressure that is out of sorts, and then EGJ outlet obstruction. So idiopathic esophageal motility has been found in patients with GERD, so I'm not talking about obesity, GERD patients up to 50% of the time, and they feel it's most likely the cause of dysphagia in this group of patients. So they can also have bolus retention because they're not squeezing enough and they have that peptic esophagitis. Everyone used to say with the IEM, and I'm not convinced, that IEM in GERD patients, it's always going to improve if you do a wrap or something like that, but I don't think that's exactly true. And I don't know the answer, I just know that I haven't seen that to be the case. And then also patients with, so think about this, patients with regurg, patients with belching, more common in patients who have underlying ineffective esophageal motility. And this is here just to let you know about it, just because it's there, that there's 3 types of morphology around the EGJ, and this can impact when you're looking for crural repair, et cetera. So this, I don't know if any of you did this for, it came out first, it's the endo flip. It came out first, they thought it'd be making some sense if we did the band, or then we tried it on the sleeve patients at NYU, and honestly, I didn't see the benefit, okay? But I have an interest in crural repair, and this is something that they're using now in foregut to assess the crura, and tells you where, based on the balloon compression, where your LES is and your crural diaphragm is, but it also tells you how tight or not your crural repair is. And while endoflip is interesting, I kind of almost feel like everyone's learning as they go to figure out what is endoflip going to do for us. And that's basically what they say at the end of this article, that endoflip is interesting, it has application, but they're still trying to figure out what it could be. So let's talk about obese patients. This is an old paper, and there were actually older papers, but I just went back to 2007. Lucky 7. But anyway, 116 obese patients, and in 41% of the patients, they had significant esophageal issues. So this was all the way back then, and you can see the breakdown of the different types of esophageal motility findings. And then here's asymptomatic patients. This was 53 patients who had no GERD symptoms whatsoever, and they found a significant, in 51%, evidence of dysmotility. And the most common dysmotility was hypomotility, which really kind of worries me in bariatrics. And then again, I'm going to give you a bunch of these because I'm trying to drive the point home. I'm not subtle. And in this case, this is I have 3 slides. This article is very good. It talked about how, and actually Nin's here. Nin wrote an article about this, how hiatal hernia was really prevalent, and in about the same number. I think his article said 34%, 36% very equivalent. But here's the thing. These were patients who had GERD, and they had significant erosive esophagitis as well. But of those, a certain percentage were asymptomatic, and they still had abnormalities. They also had abnormal manometry, which they weren't necessarily expecting. So 45% of the patients had abnormal manometry, and of the symptomatic patients, 53% had abnormal manometry. And you'll see up here that it's, can I get it there? No, is it here? Oh, no, hang on. Does that work? Oh, yeah. So you'll see here that if you add up the IEM of 25%, and then IEM and hypotensive LES, that's 35%. And so clearly both symptomatic and asymptomatic patients have erosive esophagitis. They also have ineffective esophageal motility. And then this was just the same group of patients, but you saw again, 60% of the symptomatic patients had abnormal pH testing, and among the asymptomatic patients, close to 50% had abnormal pH testing. So I don't think I have the paper here that talks about how most of the patients don't have clinically relevant GERD symptoms after sleeve, okay? But if you're not asking them and then you're not taking them for the endoscopy, you won't know. So again, these are pre-op patients waiting. Here's just another slide talking about how pH testing was positive in 65% of the patients, and then more than half had low LES hypotonia, and basically just going back to that there was no statistical significant relationship between body mass index, sex age manometry, or hiatus hernia between that and the positive pH testing. So you're just not going to be able to pick the patient that has the issue. This is a paper from 2019, again, looking at manometry and pH impedance monitoring, and similarly, they had 34% of the patients have motility disorders, and they also had they found novel disorder of jackhammer esophagus, and I'm going to talk about posed in a second. But so why in all of our obese patients that are going pre-op, that people who, and obviously it's the people that are doing foregut that are also like, I wonder about our patients that we're doing bariatrics on. Leptin concentrations are also much higher in patients with dysmotility, and they saw this in patients that were going for surgery, and that's how they figured this. I want to bring this up. Other people have talked about it. There was a whole session yesterday all day on GERD and, bariatrics. But what's happening there is the LES pressure goes down, the sphincter pressure, there's shortening of the LES length, and then you have increased intragastric pressure. In this group, it wasn't so bad. They found that there were very few that had de novo esophagitis after the sleeve, but there was and there was also improvement of the manometric dysmotility after the sleeve. I have to tell you, it's the only study that has shown that. Now, one thing that we need to think about when we think of reflux and things that we don't look at, because we all assume the sleeve empties faster, is the esophagus is doing a lot of squeezing to kind of generate that impetus to the upper part of the stomach now, the upper part of the sleeve, to empty. So when it's doing all of that excessive, swallows or peristaltic contractions, it's also resulting in some reflux. And Jacques Hempens had written about his data and looked at patients long-term, and he found that it was very common to see a bimodal peak in GERD in sleeve patients, that you might see it at 3 months, but maybe that's just related to, post-op, et cetera. But the one that you see at 2 years and persistently has probably a lot more to do with these peristaltic contractions that we're seeing. And this is a thing that we should be aware of. It's actually a paper that Barham's been involved with. It's something called POST, and that is post-obesity surgery, esophageal dysfunction. And they're seeing, in this case, they only saw it in a few number, but this is definitely something that people are talking about. And I wonder, though, because in this study they did not have pre-op manometry, whether these patients were already potentially at risk, because now we are, ruining the LES potentially. We are causing reflux, which then causes more esophageal dysmotility with the sleeve. It's also happening with bypass, so we're not alone. The sleeve is not alone in that. And then on top of that, they had a pre-existing dysmotility that was adding to this. And again, what they found in this paper, that the longer time after surgery was more associated with developing posed or other motility disorders and achalasia. And this just, I put in there that these patients do have, 14% of them had dysphagia at 4 years. This is, I put this one in, I think I have one on bypass, and I'm not being mean about the OAGB. Maybe Rami can use this, though, but this is a recent study from the new president of IFSO, Gerhard Prager, and Morris Felsenreich. This is a small study, 21 patients, but if you look at the bolded stuff, the bile in the pouch was 43%, okay? And then they also did manometry, and they did not see a change in the sphincter pressure with OAGB, but the acid exposure also did decrease with OAGB, but they found that the acid refluxes were replaced. Oh, did I go back too far? the acid refluxes were replaced by non-acid, which is the bile, obviously. So something to be concerned about and watch there. And I think you need a longer-term study to really assess esophageal function in OAGB as well. So this is a study from my friend Veronica Grodner in Argentina. And so she looked at LSG candidates, and if she found pH testing and esophageal function tests, she redirected them to bypass and then wanted to see what happened. So LES length increased, LES pressure did decrease a little bit, but it was not statistically significant, but the Demeester score decreased significantly, and so post-op, 70% of the patients had resolution, 23% improved, so that's 93% almost. And this may be why we're seeing a lot less reflux and maybe some dysmotility as well. I put this up about fundoplication mainly because, you know, I'm kind of sick of everybody talking about sleeve and GERD and bypass and how it doesn't cure GERD. Look at these guys, man. This is a fundoplication for GERD, and they have close to 40% of patients on medication long term. So we're not doing that bad considering that, because our operation is actually not to treat GERD, it's to treat severe obesity. I put this in as well. They looked at 27 studies, and they did still see with bypass an increased risk of ineffective esophageal motility, but the acid exposure was less with this, and I think that might be why we're not seeing a significant amount of change with the bypass, but there's also an increase in non-acid reflux, and which may be why some of our bypass patients are on medication, because I don't think as it says here, the esophagus here, any kind of reflux aid is noxious to the esophagus, so it's not aware if it's going to be, if it's acid or not. So that's why patients still have heartburn and reflux. And just a couple of things real quick. Bariatric patients apparently do a lot of belching. Again, that's to that non-noxious or non-acid refluxate, which might result in some issues. But also, why are these patients belching so much? And anyway, warning signs are when you talk to your patients and they tell you pre-op, I can't tolerate liquids, or if you're doing a conversion and they say, I can't get my BAT adjusted, or they have weird food intolerances, do some manometry. You have to ask these questions. Manometry can help. I had a 38-year-old female, 10 years post-RGB, and I was going to do a distalization and an HHR, and I got a manometry. She had 100% ineffective swallows, and I think if I'd done a hiatal hernia repair, I would have probably ruined her. Asymptomatic patients, or ruined her esophagus and blown out her esophageal motor is what I want to say. Asymptomatic patients can have a lot of acid reflux and dysmotility, you just don't know. Symptomatic patients will clearly have greater esophageal pathology. I think you have to do endoscopy and quality of life scores for all these patients. And I think certain patients, primarily, depending on your questioning, will need the manometry, and I do think it's more necessary in the majority of revisions, especially post-band and sleep. Thank you.
So what we're going to do is we're going to have Pierre Garneau present his talk, and if Marina, you can stay for questions. The only thing that we need to stay on time because they have another session here after we finish, and so it's going to happen. We're going to have to finish at some point. Pierre?
Thank you very much, Dr. Ponce, Dr. Matter. And yes, I will try to do it as fast as possible to make sure that we're going to be able to do the very interesting debate. Okay, my talk is about the new Canadian guideline for the management of obesity. This is my disclosure, nothing related with the presentation today. Caseload, a bunch of different type of surgery, and a lot of revisional surgery as well. As you know, Canada and US have the longest border in the world. We share a lot of things. We share business. We share professional sporting club. We share medicine as well. On the American Board of Surgery, since the last century, there's always require having a Canadian on the executive board. That means we have a lot of things in common. But for the healthcare system, the biggest difference is the fact that we have a public system since 1966. That means free medical access. And one of the issues is Canada is a federation. That means we have 10 provinces, and each province have its own Ministry of Health manage their system. The private surgery not so popular because we don't have insurance to cover the surgery exactly. And as you could imagine, each country from France, from Belgium, not Belgium, sorry, from Germany have their own surgical guideline. And as you know, ASMBS have a tremendous amount of position consensus statement. It's probably one of the best websites to have resources. But mostly those guideline or consensus are related to one aspect or maybe few aspects. And during the week at the IFSO, probably you already attend a couple of conference regarding definition and clinical practice guideline. Okay? But what makes the difference for the Canadian adult obesity guideline practice is the fact that is the type of guideline which should be comprehensive and inclusive, because the main goal was to be targeting the primary health care professional to make sure that we intend to improve the standard. Because as you know, Canada is a large country, but a lot of area don't have access to bariatric surgery. Example, Quebec and Ontario, the two provinces, I think we are maybe 50% of the population of Canada, but we cover 85% of the bariatric surgery in Canada. That means if you live in Vancouver, if you need a surgery for obesity, you will have problem to find a place. And one of the biggest, probably the starting point is from the federal government, where they don't recognize obesity as a chronic disease, even if the Canadian Medical Association and the WHO recognize as a chronic disease, as you know. And with that, we have with a lack of recognition, that means we have a trickle-down effect on the access for the treatment, and obesity is still treated as a self-inflicted disease. Okay, it's not like a global problem. And the clinical practice guideline, the center point is the patient, the healthcare professional, and we try to influence the policymaker to make sure that we will advance. And you know, those guidelines has been updated from 2007. And like I said, primarily the primary care practitioner are focused just to make sure that they understand how to evaluate any patient living with obesity and reviewing all the options they could offer to the patient. And we need to incorporate all the interprofessional primary care provider with the expert and even research. And you know, one of the big difference with our guideline, with other guideline, is the fact that during the whole process, we had patient partner. Many patients living with obesity have been involved in the process to make sure that the reality will be on the paper, on the guideline. The process was like a 5-step, where at least we need to recognize the obesity as a chronic disease and make sure that we have a good evaluation for any patient living with obesity, having a good discussion about the treatment. And you know, as a surgeon, we receive the patient most of the time at the end of the process, okay? Because patient already saw maybe the practitioner nurse, the nutritionist, the family doctor, and now they're in your office for the surgery. But we miss a lot of information, a lot of discussion they have to do with the patient to make sure that the good evaluation or the goal of the surgery or the treatment are well understood. And the last step is the follow-up, because as you know, in our surgical practice, we're not very good about follow-up. We lost a lot of patients, and the Canadian guideline tried to put a lot of emphasis on that. And this is just a graph showing, I think this type of graph should be in any practitioner, in family doctor office, any interdisciplinary group who work with patients, because they just revise all those 5 steps, make sure that the discussion is well open with the patient. The guideline has been published in the Canadian Medical Association Journal, 19 chapter. It's open source, free access and download. And every year, 2 chapters are revised, okay? And all the guidelines include not 90, but 80 key recommendations. We're going to discuss this later on. I'm going to pass fast on this. The committee behind the guideline was like an executive committee with 2 co-chairmen, primary care physician, 1 psychologist, 1 bariatric surgeon, 1 nephrologist, 16 steering committee, and around 60 author for all the chapters. This is the list of all the chapters. It's like a textbook reviewing everything from the epidemiology, the science, the pharmacotherapy, the surgery, and on. This is an example of each of a chapter. Example, this chapter written by our actual president of CABS and the past president, Dr. Laurent Berthaud. And as you see there, any chapter start with 3 different boxes. And the recommendation are going to discuss on the next slide. But if you look on the right side, they always have a key message for the healthcare provider to make sure that each chapter is well understood by the healthcare provider. And if you see the biggest box on the top, not the top, but the bottom right, there's always a message on the people living with obesity. You understand that, yeah, that's for sure. If you're a patient, don't have any training in medicine or whatever, maybe you have problem to read all the information, but at least you will find key information for each chapter. An example for the First Nation patient, as you, maybe a lot of person don't understand the fact that those person don't trust our medical system, okay? They don't want to come to you, they don't trust us. There's a lot of racism between the medical provider and the patient, and this is very important to understand that because those First Nation patients don't have any access or a lot of access for bariatric surgery. This is an example of recommendation. I'm not going to cover all the 80 recommendation, but the thing is we cover everything from pharmacotherapy, surgery, follow-up. But one of the nicest things is to make sure that people understand the level of confidence, okay? That's mean, yeah, everybody here know what is the level 1 confident, but any primary care doctor need to understand that sometimes a level 4 is just only suggestion, okay? It's not a level 1, but they need to understand that they could have a good discussion with the patient, but it's not strongly supported by the literature. To make sure that everybody find the information, Obesity Canada and CABS create a joint venture website to make sure that you're able to reach those guidelines. And one of the nicest achievement is the fact that several countries now actually use our Canadian guideline. Yeah, they did some modification. Example, the one from Chile, the one from Ireland. But that's mean, I think this is an example where we succeed with those guidelines, because other countries think they are good. And I hope that it will improve in the future. We're working actually on the pediatric guideline, not as complicated as the one for adult, but I think the future will be good. And in conclusion, obesity is prevalent, complex chronic disease, not only in Canada, it's global, and a lot of people don't have any access for treatment, and I think the nicest tool with the guideline is to make sure that we understand all the weight bias and stigma we could have with patients, understanding the root cause of the obesity, supporting our patient, and make sure we work in an interdisciplinary group. Thank you very much.
So that's exciting, and I was very aware that Chile also has taken your guidelines. I didn't know that Ireland has done it as well. Just a very quick question. So our new ASMBS IFSO guidelines, obesity class 1 with diabetes or comorbidities is not included in your guidelines. Is that right? That's not an indication. Right. Any comments on that? And if you're going to adopt it in Canada?
You know, during the next month, the Canadian Associate CABS will send a press release supporting the recommendation. Yeah, exactly. Everything will be sent for a press release, but you need to understand that that was done not many years, like 2 years ago, and it will be improved because every year we change 2 chapters at a time. That's going to change in our guideline.
So, did you get in touch with Helmut? So, anybody has any questions for Pierre or Marina? Here's Helmut. So we'll get one question asked while they get it ready. So what we're going to do is have Nin, Wynn, and Ann Rogers. They're going to present 2 or 3 cases. And Helmut and Rami, I just want you to give me an answer. Why do you think SADI or OAGB is the solution for those cases? Question?
Yes, hello, this is Felipe Cantu from Mexico. Are you planning to have another indicator beside the BMI, like body composition analysis for obesity?
You know, this is a good question because I skip one slide who explained that, and that the fact that, as you know, BMI is not the perfect way to evaluate. But as you understand, this guideline has been focused not on surgical treatment, but on comprehensive for any provider, okay? Starting from the primary care surgeon, the primary care doctor, the nutritionist, and the way of thinking about the guideline was not to be too deep inside, our kind of discussion we have in a meeting. We have to be a little bit on surface, okay? Because it could be very complex to trying to explain the difference between the level of BMI, if there's any comorbidity or yes or no. No, the focus behind the guideline was to make sure any patient will have access.
Okay, now it's time. We're gonna have the battle of the titans here, okay? So this is the debate when to use OAGB, and defending that is Dr. Rami Lutfi, and then for the SADI, Dr. Billy Helmuth. So we're gonna have 3 scenarios. It doesn't matter, okay? Doesn't matter. Go ahead and just defend it. We're gonna have 3 case scenarios, so we're gonna start off with Ann Rogers to do the first one.
All right. If we can have our slides. Okay, here we go. Let's do it. This is our requisite. Okay, first case. 45-year-old woman had a sleeve gastrectomy 3 years ago. Initial 80-pound weight loss. She had improvement of comorbidities. Was able to stop 2 out of her 3 diabetes medications, but progressively regained 55 pounds, needed to pack on more diabetes medications, interested both in further weight loss and resolution of her diabetes. And by the way, she has a completely normal-looking sleeve. And there is the sleeve on the upper GI. Debate.
So what's your question?
What's my question? Whether this should be treated better with SADI or with OAGB.
It's clearly OAGB. No, it's clearly OAGB because, again, we have other modalities we can add to that to facilitate, such as medications. We don't have to commit her to a malabsorptive operation of such severity that this woman who already has joint problems and joint pain may be at risk for osteoporosis, nutritional deficiencies. Let's start with something that will address what caused all of her problem, and that was the weight regain, and the diabetes will go away.
I think he just gave my answer. I was going to say the same thing because the data, the French data at the least, talk so much about bone issues and nutritional problem. So I'm not sure what Helmut is talking about. But aside of all that debate, is the big thing that's going to come out, I think in all these cases, is the limb length. And at least with SADI, you know your common channel. You count that way. But with OAGB, we count all that biliary limb. No one knows how much bowel. So you're wrong. I'm sorry.
Except for the fact I count that.
Does the joint pain, I think there's a little hint there, does the joint pain affect your decision-making process and the treatment for joint pain?
Well, it depends what the joint pain is from. If she has an orthopedic knee replacement that's needed, again, she doesn't need to have a powerful sledgehammer. We don't argue whether the SADI is the best, fastest weight loss operation that we have or that it's the most sustained. That's been established. But we don't need to take out a hammer to get 55 pounds down.
Well, what about marginal ulcer formation?
Yes.
Let me be more clear.
Yeah, I was going to address that. Yeah, thank you. Helmut was running so much, I think he was tired, so I'll answer for him. I think, and we do talk about this with our patients, Samer. Thank you. Sleeve and bypass and the medication, because eventually this woman who's still young is going to be on NSAIDs and is going to complicate things. So I believe having SADI, that means she has preserved sleeve, and NSAIDs will be much more benign.
The only deficit here is that my Syrian friend has a crystal ball and predicts the future. She's going to be on NSAIDs. And that's not a reason to make a patient undergo a massive operation like that because we've predicted her future. She doesn't need to lose 150 pounds. She doesn't need to lose 200 pounds. We've already established that this patient, most likely in the United States and the average surgeon, is going to have a Roux-Y, which has the same exact concern you have. And so how easy is it to treat marginal ulcers? Everybody treats them with PPIs and monitors them, and the incidence is still low in many of our operations. So that is not a powerful argument to make her have such a severe operation.
Thank you.
Okay, let's take a vote. Who would vote for OAGB for this patient? Who would vote for Sadie? There you go. Would anybody vote for medication management? Oh, boy, about as many as would do OAGB. Sadie wins. Yay! All right.
Okay, we could
right.
have combination management.
Next case. Can we get the slide for the next case? So here's a good one for both of you. And okay, next slide. Okay, never mind. I'll just use this. Oh, this is your slide. No, can we go back to the previous slide? Yeah, go ahead. Take a picture of that. Take a picture before it's gone. All right, you good? So is it possible to go back to the last slide deck? Ooh, yeah. Okay, here it is. We're going to continue on. Okay, so this 38-year-old gentleman who underwent a sleeve gastrectomy 5 years ago for morbid obesity, he did very well in terms of weight loss. Didn't really have much of comorbidities when he started, but persistent complaint of nausea, vomiting, reflux. That's his past medical history as noted there. So, oh, what happened to, is this the slide? Yeah, is this? So essentially, the upper GI demonstrated a convoluted sleeve. We're supposed to show you the convoluted sleeve, but unfortunately, it is not working. Okay. Very tortuous and convoluted. And there is essentially a narrowing in about the mid aspect of it. So we need Rami to go first to defend the Sadie.
Yeah, I don't know. I would vote against me. I mean, it's fun to do this, but it's hard for me to defend. I mean, definitely Sadie should not be done. I've been trying to think why, with a convoluted sleeve, with a stricture, if there is truly stricture, nausea, and vomiting, this patient has symptomatic stricture, and yeah, this guy has this gentleman problem first is he's in trouble with a symptomatic sleeve stricture that needs to be dealt with. Now, if this gentleman agrees to 2 steps operation, I would fix that, depend how bad is the sleeve. But man, this is, like either stenting the twist, do omentopexy. But if in one session to go with a twisted sleeve with symptomatic, again, very important, symptomatic stricture, it's very hard for me to justify leaving the sleeve. If I'm very, very stubborn, I can do omentopexy and twisted, but that will be really more stubborn. I don't agree. I'm sorry with this, AD. So you win already.
Well, first, do you think we can even rescue this?
Oh, I think we can completely rescue it. I mean,
using omentopexy and anything inside of.
Well, what we don't know until the time of surgery is what this sleeve even looks like. So it may be adhesions. It may be a bunch of omentum trapped to that big greater curvature staple on. You may be able to rescue it and it looks good and then go on with your SADI, but you would have to actually defend the idea of a SADI, which in this case you have a patient who is very difficult to defend unless you're going to say, once I fix it, he's going to eat more, so I'm going to, remember that crystal ball, he predicts the future. So he could have defended it, but in this case, he clearly needs an operation that is going to decompress the higher pressure system that has resulted for whatever reason, and that's not going to happen with a SADI.
Thank you, Dr. Billy. We have a question from the floor.
This is a renal transplant patient. Probably he needs a new transplant, renal transplant. Torsion after 5 years, I don't know. It's not addition. So he needs a new transplant.
Okay. Dr. Peterson, did you have a question? Nope. You're just...
New transplant. Rami, do you want to comment on that? New kidney transplant.
Why are we saying that? I'm not sure. Sorry, you want me to come? Rich,
Well,
yeah.
no, I guess I did have a question. I just think that sounds like the patient needs a bypass. I know we're debating these two. It just sounds like, and that's why Rami was.
Correct, it's not an option. I would have loved to defend that.
Let's have the third case.
Can you go back to the first one?
Yeah, I think.
There we go. Okay, last case. 50-year-old man had an open gastric bypass 20 years prior, BMI of 75. He lost half his body weight, which was amazing, lost his job, progressive weight gain, got back to a BMI of 71. He wants to again experience significant weight loss. He has a normal, intact gastric bypass. He has a number of midline hernias, but that is neither here nor there. What are the options?
So if we have a surgical plan between these two operations, that's going to require that this guy have his bypass reversed. And then, so what we're basically dealing with here is a non-compliant patient of some sort. He's back at a BMI of 71. He has an intact bypass, which we can assume the definition of it should work. The last operation you should give him is a SADI, which requires him to be a compliant patient to have that operation. He's going to have far more responsibility for taking vitamins. He's going to have more responsibility for avoiding certain foods that are going to cause diarrhea, that are going to cause worse absorption. He's going to have to eat better foods. So you should not give a severely non-compliant patient an operation that would require more responsibility on his part.
Where does it say he's non-compliant?
Yes, thank you. Don't steal it. Don't steal it. Yeah, so for all the young people in the room, just please ignore what you just heard. People with weight recurrence are not necessarily non-compliant. Obesity is a chronic disease, and obesity could recur. So while this gentleman could be non-compliant to some extent, we know that weight recurrence is a phenomenon that we struggle with. So I don't agree at all. For this gentleman, an operation like SADI with a very well calculated terminal ileum length would be just ideal, because both the OAGB and the SADI would require a lot of technical difficulty to lyse the adhesion after an open operation, put the anatomy together and destroy it again. So I would say a well done SADI would be much better for this gentleman.
Okay, that's just absurd. We initially lost half of his total body weight to a BMI of 37. He goes, and then we're using a SADI now to treat the psychological impact of losing your job, becoming depressed, and then doing what? Becoming non-compliant. That he only became a problem, and he spectacularly gained from 37 BMI to 71. And so we are treating a compliance issue here. We're not treating weight regain in its normal sense. And this is one where you have to look at the patient and actually take into reality who the patient is, what life is he living. And he's going to need a massive psychological evaluation for us to know who he is. But the last operation I would give him is one that requires.
Dr. Billy, let's assume the gentleman, before being referred to, was evaluated thoroughly by a dietitian and a psychologist, and they told you, and you agreed in a multidisciplinary setting, that this was a good surgical candidate. which operation are you still sticking to your guns?
Oh, absolutely. You know, this kind of patient does not need all of the counting that are required, all of the small bowel to be mobilized, multiple hernias. We'll keep it simple, and we'll start with acknowledging his gastric bypass for whatever reason didn't work for him, and rescuing him with an OAGB protects him from any non-compliance issues that may exist.
May I remind you, you just said you count the entire small bowel, so now you're changing your mind. Either way, I think we do.
I count to make sure there's 350 centimeters of common channel beyond. I don't see the reason. If I have 350, I challenge everyone to show me the papers that say 350 centimeters of common channel will promote malabsorption. Every paper on OAGB that talks about malabsorption fails to document what the distal small bowel channel was. And the ones that you find that talk about malnutrition that required surgery all document small bowel channels common of less than 300. So that's the reason that's talking about, not the whole thing.
A technical question. You already have the Roux-en-Y. What about increasing the BP limb?
I'm gonna reverse it back to normal anatomy. I'm not gonna resect the roux limb unless I'm forced to. That's gonna be operation number 1. When that heals, I'll come back and do the definitive one.
That's fair. No resection for sure. I agree, because either way you need small bowel. So no, I somehow I agree with the last thing you said.
All right. Yes. One question from the floor.
Yes, in this case, one anastomosis bypass is not an option because it doesn't make sense to do a gastro-anastomosis and then cut again the stomach to make a longer gastric pouch. So anatomy findings is really important to make a decision if SADIS is an option, but one anastomosis is not an option.
No, it's clearly an option because either way you have to reverse the bypass to do a
And then
SADI.
cut
You have
again
to reverse the bypass.
and then connect and cut again there.
Yeah, you do. Either operation you have to. Either
No, that
operation.
doesn't make sense.
You can't do a SADI with a Roux-en-Y in
Cannot
place like this.
connect the stomach and cut it again.
Yeah.
5 centimeters.
But
No,
those are
doesn't
the
make
choices
sense.
we're given.
That's
So
not possible.
if you want to do a SADI, I can't convert a SADI with a Roux-Y without reconnecting the gastric pouch back to the gastric.
And it's a 71 patient
Unless you-
BMI.
yeah, unless
so
they did an
it doesn't
OAGB.
make sense. It's not enough.
All right. We agree to disagree.
Okay, let's vote. Who voted for OAGB? Sadi? Other option?
Yeah, there must be another option.
Very good. So,
Distalization.
thank you very much for attending this session. Look forward to see you in the farewell dinner if you come, and then hopefully we'll see you in our meetings in ASMBS and Canada meetings. Thank you.
Yes. Yes. Are you going there?
Yeah, I'll present our experience with
Excellent. That was very exciting. Very exciting. Oh, here are the Brazilians.
You finished
Of course. Punctual.